Four types of motion occur at synovial joints: gliding, angular, rotational, and then special movements, which are motions that occur only at specific joints. I will talk about angular, rotational, and the special movements first, and finish up with gliding movements. On this slide, you're seeing some examples of angular motion. Angular motion either increases or decreases the angle between two bones. These movements may occur at many of the synovial joints. They include the following specific types: flexion and extension, hyperextension, lateral flexion, abduction and adduction, and circumduction. Flexion is movement in an anterior-posterior plane of the body that decreases the angle between the articulating bones. Bones are brought closer together as the angle between them decreases. Examples include bending your fingers toward your palm to make a fist, bending your forearm toward your arm at the elbow, flexion at the shoulder when you raise an arm anteriorly, and flexion of the neck when you bend your head anteriorly to look down at your feet. The opposite of flexion is extension, which is movement in an anterior-posterior plane that increases the angle between the articulating bones. Extension is a straightening action that usually occurs in the sagittal plane of the body. Straightening your arm and forearm until the upper limb projects directly away from the anterior side of your body, or straightening your fingers after making a clenched fist, are examples of extension. Flexion and extension of various body parts is illustrated in your textbook. Hyperextension is the extension of a joint beyond 180 degrees. For example, if you extend your arm and hand with the palm facing inferiorly, and then raise the back of your hand as if admiring a new ring on your finger, the wrist is hyperextended. If you glance up at the ceiling while standing, your neck is hyperextended. Lateral flexion occurs when the trunk of the body moves in a coronal plane, or coronal I should say, coronal plane, laterally away from the body. This type of movement occurs primarily between the vertebrae in the cervical and lumbar regions of the vertebral column. Abduction will be considered on the next slide. Abduction means to move away. It is a lateral movement of a body part away from the midline. Abduction occurs when either the arm or the thigh is moved laterally away from the body midline. Abduction of either the fingers or the toes means that you spread them apart, away from the longest digit, which is acting as the midline. Abducting the wrist, also known as radial deviation, involves pointing the hand and fingers laterally away from the body. The opposite of abduction is adduction, which means to move toward, and is the medial movement of a body part toward the body midline. I think of abduction as a child that's being abducted, taken away from its family. And adduction, its name tells you to add things together, bring them together. Adduction occurs when you bring your raised arm or thigh back toward the body midline, or in the case of the digits, toward the midline of the hand. An example of both abduction and adduction would be you doing jumping jacks. When you take your legs apart and your arms swing out to the side and over your head, that's abduction. And when you bring your jump back in and the legs come in together and your hands go down by your side, that's adduction. So now you can do your jumping jacks by saying abduction, adduction, abduction, adduction. Adducting the wrist, also known as ulnar deviation, involves pointing the hand and fingers medially towards the body. Abduction and adduction of various body parts are shown in your textbook. Circumduction is a sequence of movements in which the proximal end of an appendage remains relatively stationary while the distal end makes a circular motion. The resulting movement makes an imaginary cone shape. For example, when you draw a circle on the blackboard, your shoulder remains stationary while your hand moves. The tip of the imaginary cone is the stationary shoulder, while the rounded base of the cone is the circle the hand makes. Circumduction is a complex movement that occurs as a result of a continuous sequence of flexion, abduction, extension, and adduction. Rotation is a pivoting motion in which a bone turns on its own longitudinal axis. Rotational movement occurs at the atlantoaxial joint, which pivots when you rotate your head to gesture, "No, Kara, no." Some limb rotations are described as either away from the median plane or toward it. For example, lateral rotation or external rotation turns the anterior surface of the femur or humerus laterally, whereas medial rotation or internal rotation turns the anterior surface of the femur or humerus internally. I like to think of this like a ballerina who's doing their toe points, and they toe point out, which is lateral rotation, toe point in, which is medial. Or, if you're not a dancer, hey, when you're driving and you press on the gas, you are doing lateral rotation of your femur, and when you step on the brake, you're doing medial rotation. Pronation is the medial rotation of the forearm so that the palm of the hand is directed posteriorly or inferiorly. The radius and ulna are crossed to form an X. Supination occurs when the forearm rotates laterally so that the palm faces anteriorly or superiorly if the person is lying down, and the radius is parallel with the ulna. In supination, the person would be in anatomic position. The forearm must be supinated to be in anatomic position. Some motions occur only at specific joints and do not readily fit into any of the functional categories previously discussed, like rotational motion, angular motion, and soon I'll talk about gliding motion. These special movements include depression and elevation, dorsiflexion and plantar flexion, inversion and eversion, protraction and retraction, and opposition. A special consideration is excursion. There's medial and lateral, and some textbooks actually put this as a gliding rotation or a gliding motion, which is technically true. But when we speak of excursion, we are specifically speaking of a joint in the mouth that allows you to chew. More on this to come. Depression is the inferior movement of a part of the body. Examples of depression, and I don't mean being sad, I mean movement, include the movement of the mandible while opening your mouth to chew food, and the movement of your shoulders in an inferior direction. Elevation is the superior movement of a body part. Examples of elevation include the superior movement of the mandible while closing your mouth at the temporomandibular joint, and at the movement of the shoulders in a superior direction like you were shrugging your shoulders. Dorsiflexion and plantar flexion are limited to the ankle joint. Dorsiflexion occurs when the talocrural or ankle joint is bent such that the superior surface of the foot and toes moves toward the leg. This movement occurs when you dig in your heels, and it prevents your toes from scraping the ground when you take a step, meaning walking on your heels. In plantar flexion, movement at the ankle joint permits extension of the foot so that the toes point inferiorly, like when a ballerina is standing on her tiptoes. She is in full plantar flexion. I remember plantar flexion as your toes are pointed toward the plants in the ground, point downward. Inversion and eversion are movements that occur at the intertarsal joints of the foot only. In inversion, turning inward, the sole of the foot turns medially. That would be like you walking on your lateral malleolus. In eversion, the sole turns to face laterally. That would be like you walking on your medial malleolus. Some orthopedists and runners use the terms pronation and supination when describing foot movements, instead of using inversion and eversion. Inversion is foot supination, whereas eversion is foot pronation for you runners out there. Protraction is the anterior movement of a body part from an anatomic position, as when moving your jaw anteriorly at the temporomandibular joint, shown here on the screen. He's jutting his jaw outward. Or hunching your shoulders anteriorly by crossing your arms. I like to think of as a pubescent teenager, pubescent female. She oftentimes has protraction because she is worried about her breast development. She doesn't want people to see her little mosquito bites growing into developing breast tissue, as I like to say. But as soon as she learns what boobs can do for her in her life, she will no longer protract, but instead she's going to retract and throw her shoulders back and stick her breasts out, because that will get her noticed, right? So with retraction, it is a posterior directed movement from the anatomic position. Again, think of it as pulling the shoulders back to thrust out the chest. At the carpometacarpal joint, the thumb moves toward the palmar tips of the fingers as it crosses the palm of the hand. This movement is called opposition. It enables the hand to grasp objects and is the most distinctive digital movement in humans. The opposite movement is called reposition. Again, a special consideration is excursion. If you were to move your mandible from side to side, that is called medial and lateral excursion, and it helps to let you chew. This is considered to be a gliding motion, and more on this in the next slide. This table summarizes the kinds of movements at synovial joints. Again, they're broken down into four main categories: gliding, angular, rotational, and then the special movements. One of the special movements I told you about was medial and lateral excursion. That's sort of like you swinging your jaw side to side. That is technically considered to be a gliding motion of your jaw, in which case two opposing articular surfaces, in this case the temporomandibular joint, the bones are sliding past each other in a certain amount of direction, like side to side in this case, and the amount of movement is actually relatively slight. This slide is not officially taken from a section in your textbook. It is basically just to reiterate some factors that can influence joint stability. Whether or not they actually do influence a joint's stability is dependent on the kind of joint that we're talking about. And the picture in this slide is reiterating, again, the idea of this inverse relationship between mobility and stability. The more stable a joint is, the less mobile it is. So what can influence joint stability? It can certainly be the articular surfaces, though seldom do they actually play a major role in joint stability. However, there are some classic examples where clearly the articular surfaces do play a role. For example, the elbow, the knee, and particularly the hip. If we think about the big head of the femur resting in the acetabulum, the indented region of the os coxae, that clearly is a very deep ball and socket. And so the articular surfaces do help in the joint stability there. The shapes of the joint determine the type of movement possible. Hinge joint in the case of the elbow and the knee versus ball and socket for the hip. Ligaments certainly reinforce the joint stability. The more ligaments there are, the stronger the joint is. However, if the ligaments are stretched, in the case of when a joint is dislocated, this can lead to the deterioration of the joint stability. Muscle tone. There are some classic examples where the muscle tone is actually very important for joint stability. And a classic example of that is actually the musculature that surrounds the glenohumeral joint or shoulder joint. The muscle tone can keep tension and keep a joint intact. And additionally, proprioceptors, these are stretch receptors in the muscle tone, can send information up to the brain where you feel your muscles are being stretched. And this actually signals you to stop whatever motion you're doing before you compromise the joint that these muscles are acting around. Now I would like to talk about some special case joints, ones that are particularly clinically relevant. I'd like to start with the shoulder or glenohumeral joint. It is commonly referred to, as I just said, as a shoulder joint. It is a ball and socket joint formed by the articulation of the head of the humerus and the glenoid cavity of the scapula. It permits the greatest range of motion, and as you saw from the previous slide, then the greatest range of motion means you have the least stability. So it's the greatest range of motion of any joint in the body. And so it is also the most unstable joint in the body and the one most frequently dislocated. However, frequently dislocated versus the most easily dislocated, that's where textbooks tend to blur the lines. So according to most of my studies, the TMJ or temporomandibular joint is the most easily dislocated, but not necessarily the most frequently dislocated. So in this case, the shoulder joint is the most frequently dislocated. The fibrocartilaginous glenoid labrum encircles and covers the surface of the glenoid cavity. And the purpose of this is to actually deepen that cavity and make it a slightly deeper ball and socket joint. A relatively loose articular capsule attaches to the surgical neck of the humerus. The glenohumeral joint has several major ligaments, just to name a few, and for my students, I don't ask you to identify them or name them for your lecture exam, but in lab we do have a shoulder joint model where you can see some of these ligaments. For example, the coracoacromial joint, its name again, or ligament I should say, its name tells you what bone or structure of a bone the ligament attaches to. So it attaches to the coracoid process of the scapula and the acromial process of the scapula. The coracohumeral ligament is a thickening of the superior part of the joint capsule, and it runs from the coracoid process to the humeral head. There are glenohumeral ligaments, and these are thickenings of the anterior portion of the articular capsule, and these ligaments are often indistinct or absent and provide only minimal support. And we can continue on with the transverse humeral ligament, etc. Now, in addition, the tendon of the long head of the biceps brachii travels within the articular capsule and helps stabilize the humeral head in the joint. Very important joint stabilizer, that tendon of the long head of the biceps brachii. Ligaments of the glenohumeral joint strengthen the joint only minimally. Most of the joint strength, as I said before, is due to the muscles surrounding it. In this case, the muscles that surround it are called or referred to as the rotator cuff muscles. These muscles include the supraspinatus, infraspinatus, teres minor, and the subscapularis, and they work as a group to hold the head of the humerus in the glenoid cavity. The tendons of these muscles encircle the joint, except for the inferior portion, and fuse with the articular capsule. Because the inferior portion of the joint lacks rotator cuff muscles, this area is weak and is the most likely site of injury. Now, what's a bursa? A bursa is a fibrous, sac-like structure that contains synovial fluid and is lined by a synovial membrane. Bursae, plural, occur around most synovial joints and also where bones, ligaments, muscles, skin, or tendons overlie each other and rub together. Bursae may be either connected to the joint cavity or completely separate from it. They are designated to alleviate the friction resulting from the various body movements, such as a tendon or ligament rubbing up against a bone. An elongated bursa, called a tendon sheath, wraps around tendons where there may be excessive friction. Tendon sheaths are especially common in the confined spaces of the wrist and ankle, but we do find a bursa, a sac of synovial membrane. Now, this sac of synovial membrane is shown here in blue in my picture. You see several bursae. There's even one around the tendon of the long head of the biceps brachii. A bursa is not a synovial joint, okay? It doesn't have all the 7 classic parts of a synovial joint. It is basically a sac of synovial membrane. And in the case of the shoulder joint, like I said, shown in this picture in blue, we see several bursae. And their purpose is basically to decrease the friction at the specific places on the shoulder where both tendons and large muscles extend across the articular capsule. So there are, again, a large number of bursae in the shoulder joint. Let's take a clinical view on shoulder joint dislocations. Like I said, shoulder joint is the most frequently dislocated, but according to my studies, the second most easily dislocated. It might be that you think I'm splitting hairs, but it's a shallow joint and it has the greatest mobility, but that comes at a price: lack of stability. Dislocation means a joint that's out of place, apart from its articulation between bones. A joint injury dislocation in which the articulating bones, like I said, have separated, and it's very common in the shoulder. Although these injuries can occur at any of the 3 shoulder joints described in the chapter, the shoulder joint is a very complex joint. They are more common at the acromioclavicular joint or the glenohumeral joint. The term shoulder separation refers to a dislocation of the acromioclavicular joint. This injury often results from a hard blow to the joint, as when a hockey player is slammed into the boards, for those of you who play hockey, or one falls onto the shoulder. Symptoms include tenderness and edema, which means swelling, in the area of the joint, and pain when the arm is abducted more than 90 degrees. Because in this position, significant movement occurs between the separated bone surfaces. Additionally, the acromion will appear very prominent and pointed. Treatment can range from rest to surgery depending on the severity of the dislocation. So again, you get kind of a pointed appearance to the shoulder. The glenohumeral joint dislocations are very common because this joint is very mobile and yet unstable. These dislocations usually occur when a fully abducted humerus is struck hard. For example, when a quarterback is hit as he is about to release a football, or when a person falls on an outstretched hand. The initial blow pushes the humerus into the inferior part of the articular capsule where it's weakest and tears it as the humerus dislocates. Now again, that glenohumeral joint is weakest inferiorly as well as anteriorly. Once the humeral head is no longer held in place by the capsule, the anterior thorax or chest muscles pull superiorly and medially on the humeral head, causing it to lie just inferior to the coracoid process. The result is that the shoulder appears flattened and squared off because the humeral head is dislocated anteriorly and inferiorly to the glenohumeral joint capsule, again, where it's weakest. That joint is weakest anteriorly and inferiorly. Some glenohumeral dislocations can be repaired by popping the humerus back into the glenoid cavity, and I described what this meant in lab. And I told you about how this happened to my husband and how the nurse had to hold my husband's arm outward, abducted, and then the physician came in at him with his knee on the anterior side and just used his knee to thrust my husband's humeral head back into the glenoid cavity. More severe dislocations may need surgical repair, and once you dislocate your shoulder in this fashion, the ligaments get stretched, they get weakened, and you are more likely to dislocate your shoulder in the future. The knee joint is the largest and most complex diarthrosis, or very mobile joint of the body. It primarily functions as a hinge joint, but when the knee is flexed, it is also capable of slight rotation and lateral gliding. Structurally, the knee is composed of two separate articulations. The tibiofemoral joint is between the condyles of the femur and the condyles of the tibia, and two, the patellofemoral joint is between the patella and the patellar surface of the femur. The knee joint has an articular capsule that encloses only the medial, lateral, and posterior regions of the knee joint. The articular capsule does not cover the anterior surface of the knee joint. Rather, the quadriceps femoris muscle tendon passes over the anterior surface. The patella is embedded within this tendon, and the patellar ligament extends beyond the patella and continues to its attachment on the tibial tuberosity of the tibia. Thus, there is no single, unified capsule in the knee, nor is there a common joint cavity. Posteriorly, the capsule is strengthened by several popliteal ligaments. On either side of the joint are two collateral ligaments that become taut on extension and provide additional stability to the joint. The fibular collateral ligament, also called the lateral collateral ligament, reinforces the lateral surface of the joint. This ligament runs from the femur to the fibula and prevents hyperadduction of the leg at the knee. In other words, it prevents the leg from moving too far medially relative to the thigh. The tibial collateral ligament, or medial collateral ligament, reinforces the medial surface of the knee joint. This ligament runs from the femur to the tibia and prevents hyperabduction of the leg at the knee. In other words, it prevents the leg from moving too far laterally relative to the thigh. This ligament is attached to the medial meniscus of the knee joint as well. So an injury to the tibial collateral ligament usually affects the medial meniscus. Deep to the articular capsule and within the knee joint itself are a pair of C-shaped fibrocartilage pads located on the condyles of the tibia. These pads, called the medial meniscus and the lateral meniscus, partially stabilize the joint medially and laterally, act as cushions between the articular surfaces, and continuously change shape to conform to the articulating surfaces as the femur moves. Again, these are fibrocartilage. Also deep to the articular capsule of the knee joint are two cruciate ligaments, which limit the anterior and posterior movement of the femur on the tibia. These ligaments cross each other in the form of an X, hence the name cruciate, which means cross. The anterior cruciate ligament, or ACL, runs from the posterior femur to the anterior side of the tibia. When the knee is extended, the ACL is pulled tight and prevents hyperextension. The ACL prevents the tibia from moving too far anteriorly on the femur. The posterior cruciate ligament, or PCL, runs from the anterio-inferior femur to the posterior side of the tibia. The PCL becomes taut on flexion, and so it prevents hyperflexion of the knee, and the PCL also prevents posterior displacement of the tibia on the femur. Let's talk about some clinically relevant knee injuries. Although the knee is capable of bearing much weight and has numerous strong supporting ligaments, it is highly vulnerable to injury, especially among athletes. Because the knee is reinforced by tendons and ligaments only, ligamentous injuries to the knee are very common. The tibial collateral ligament is frequently injured when the leg is forcibly abducted at the knee, such as when a person's knee is hit on the lateral side. Because the tibial collateral ligament is attached to the medial meniscus may be injured as well. Injury to the fibular collateral ligament can occur if the medial side of the knee is struck, resulting in hyperadduction of the leg at the knee. This type of injury is fairly rare, in part because the fibular collateral ligament is very strong, and also because medial blows to the knee are not common. Let's admit it, how likely is someone to get in between your legs to knock you on the mid-side or medial side of your knee? The anterior cruciate ligament, ACL, can be injured when the leg is hyperextended. For example, if a runner's foot hits a hole. I've done that so many times. Because the ACL is rather weak compared to the other knee ligaments, it is especially prone to injury. To test for ACL injury, a physician asks a person to sit on the table, their knees are bent, and the physician will gently tug anteriorly on the tibia. In other words, the physician will grab the lower leg and with the other hand brace him or herself with the thigh and see if they can wiggle anteriorly the tibia forward. And this is called the anterior drawer test, like pulling a drawer forward. Too much forward movement indicates an ACL tear. Conversely, a PCL tear may occur if the leg is hyperflexed, or if the tibia is driven posteriorly on the femur. PCL injury occurs rarely because this ligament is rather strong, and the physician will do a posterior drawer test, which means, again, the patient sitting down, knees are bent over the table, and if the physician can push the tibia posteriorly, like pushing a drawer closed, that's indicative of a PCL tear. The menisci also may be prone to injury. Tears in the meniscus may occur due to blows to the knee or due to the general overuse of the joint. Because the menisci are composed of fibrocartilage, they cannot regenerate and often must be surgically treated. The, quote, unhappy triad of injuries refers to a triple injury of the tibial collateral ligament, medial meniscus, and anterior cruciate ligament. This is the most common type of football injury. It occurs when a player is illegally clipped by a lateral blow to the knee and the leg is forcibly abducted and laterally rotated. If the blow is severe enough, the tibial collateral ligament tears, followed by tearing of the medial meniscus, as these two structures are connected. The force that tears the tibial collateral ligament and the medial meniscus is thus transferred to the ACL. Because the ACL is relatively weak, it tears as well. By the way, it's not just football players, but soccer players are very commonly illegally clipped. We call this an illegal slide tackle, and they oftentimes have the unhappy triad as well. The treatment of ligamentous knee injuries depends on the severity and type of injury. Conservative treatment involves immobilizing the knee for a period of time. Surgical treatment can include repairing the torn ligaments or replacing the ligaments with a graft from another tendon or ligament. Many knee surgeries now may be performed with arthroscopy. Arthroscopy is a type of conservative surgical treatment where a very small incision is made in the knee and an arthroscope, an instrument with a camera and light source, is inserted in the knee, allowing the surgeon to clearly see the surgical area without having to make large incisions. The temporomandibular joint, or TMJ, is formed by the articulation of the head of the mandible with the articular tubercle of the temporal bone anteriorly and the mandibular fossa posteriorly. This small, complex articulation is the only mobile joint between skull bones. The TMJ has several unique anatomic features. A loose articular capsule surrounds the joint and promotes an extensive range of motion. The TMJ is poorly stabilized, and thus a forceful anterior or lateral movement of the mandible can result in partial or complete dislocation of the mandible. It is the most easily dislocated joint. It contains an articular disc, which is a thick pad of fibrocartilage separating the articulating bones and extends horizontally to divide the joint cavity into two separate chambers. As a result, the TMJ is really two synovial joints, one between the temporal bone and the articular disc, and a second between the articular disc and the mandible. The TMJ exhibits hinge, gliding, and some pivot joint movements. It functions like a hinge during jaw depression and elevation while chewing. It glides slightly forward during protraction of the jaw for biting, and glides slightly from side to side, that would be medial and lateral excursion, to grind food between the teeth during chewing. The elbow joint is a hinge joint composed primarily of two articulations. One, the humero-ulnar joint, where the trochlear notch of the ulna articulates with the trochlea of the humerus, and two, the humero-radial joint, where the capitulum of the humerus articulates with the head of the radius. These joints are enclosed within a single articular capsule, and this joint can be dislocated. It is considered to be the third commonly dislocated joint, and some textbooks say it's the third most easily dislocated joint, even though some textbooks say it's a very stable joint. Let's review some clinical aspects for the elbow. The term subluxation refers to an incomplete dislocation in which the contact between the bony joint surfaces is altered, but they are still in partial contact. In subluxation of the head of the radius, the head is pulled out of the annular ligament, annular ligament. The layman's terms for this injury includes pulled elbow, or as I learned in anatomy, nursemaid's elbow or slipped elbow. This injury occurs commonly and almost exclusively in children, typically those younger than age 5, because a child's annular ligament is thin and the head of the radius is not fully formed. After age 5, both the ligament and the radial head are more fully formed, so the risk of this type of injury lessens dramatically. However, it may occur if an individual pulls suddenly on a child's pronated forearm. Luckily, treatment is very simple. The pediatrician applies posteriorly placed pressure to the head of the radius while slowly pivoting the child's forearm, supinating it, and this basically screws the radial head back in the annular ligament. I should tell you that nursemaid's elbow in a child younger than 5 raises eyebrows and is suspicious of child abuse, like a parent yanking on the child's arm. "Come here! Follow me! Come over here!" and pulling them. The hip joint, also called the coxal joint, is the articulation between the head of the femur and the relatively deep concave acetabulum of the os coxae. A fibrocartilaginous acetabular labrum further deepens this socket. It's very similar to the glenoid labrum. The hip joint's more extensive bony architecture is therefore much stronger and more stable than that of the glenohumeral joint. Conversely, the hip's joint's increased stability means that it is less mobile than the glenohumeral joint. The hip joint must be more stable and thus less mobile because it supports the body weight. However, the hip joint can be weakened when the hip is slightly flexed and laterally rotated. That would be the femur slightly flexed and laterally rotated, like when a person is driving and they're pressing on the gas. If you were to be hit in a front-end collision, that impact with your foot on the gas pedal, that's enough to knock the head of the femur out of the acetabulum. I'd like to finish up our lecture with some clinical perspectives on joint disorders. Some of these words I've been using throughout the lecture. For example, like a dislocation of a joint or luxation. But what is a sprain? A sprain is a stretching or tearing of ligaments without fracture or dislocation of the joint. For example, like an ankle sprain results when the foot is twisted, almost always due to over-inversion. What about other types of joint disorders? How about a discussion on arthritis? It is a group of inflammatory or degenerative diseases of joints that occur in various forms. Each form presents the same symptoms: swelling of the joint, pain, and stiffness. It is the most prevalent crippling disease in the United States. Some common forms of arthritis are gouty arthritis, osteoarthritis, and rheumatoid arthritis. Gouty arthritis is typically seen in middle-aged and older individuals and is more common in males. Often called gout, this disease occurs as a result of an increased level of uric acid, a normal cellular waste product from metabolism of nucleotides, DNA. This abnormal level causes urate crystals to accumulate in the blood, synovial fluid, and synovial membranes. The body's inflammatory response to the urate crystals results in joint pain. Gout usually begins with an attack on a single joint, often in the great toe, of all places, and later progresses to other joints. Eventually, gouty arthritis may immobilize joints by causing fusion between the articular surfaces of the bones. Often non-steroidal anti-inflammatory drugs, or NSAIDs, are used to alleviate symptoms and reduce the inflammation. Osteoarthritis is the most common type of arthritis. This chronic degenerative joint condition is termed wear and tear, quote-unquote, arthritis because of its prevalence in weight-bearing joints and its association with older adults. The entire joint is affected, but the articular cartilage appears to break down first. Eventually, bone rubs against bone, causing abrasions on the bony surfaces or eburnation. Sorry about that. Without the protective articular cartilage, movements at the joints become stiff and painful. Weight-bearing joints most affected by osteoarthritis are those of the hips, knees, feet, and cervical and lumbar regions of the spine. Other joints commonly affected include the shoulders and interphalangeal joints. Osteoarthritis is typically seen in older individuals, although more and more athletes are experiencing arthritis at an earlier age due to the repetitive stresses placed on their joints. NSAIDs are used to alleviate the symptoms of osteoarthritis. Rheumatoid arthritis is typically seen in younger and middle-aged adults and is much more prevalent in women. It presents with pain and swelling of the joints, muscle weakness, osteoporosis, and assorted problems with both the heart and the blood vessels. Rheumatoid arthritis is an autoimmune disorder in which the body's immune system targets its own tissues for attack. Although the cause of this reaction is unknown, it often follows infection by certain bacteria and viruses that have surface molecules similar to molecules normally present in the joints. When the body's immune system is stimulated to attack the foreign molecules, it also destroys its own joint tissue, thus initiating the autoimmune disorder. Rheumatoid arthritis starts with synovial membrane inflammation, and I show that here in the picture, not the synovial membrane inflammation, but this rheumatoid arthritis joint disfiguration in the top right picture. Fluid and white blood cells leak from the small blood vessels into the joint cavity, causing an increase in synovial fluid volume. As a consequence, the joint swells and the inflamed synovial membrane thickens. Eventually, the articular cartilage and, often, the underlying bone become eroded. Scar tissue later forms and ossifies, and bone ends fuse together, a process called ankylosis that immobilizes the joint. Two types of medication are often prescribed to treat rheumatoid arthritis, and I discuss this very, very early on in my physiology class. A, the faster-acting first-line medications include NSAIDs, non-steroidal anti-inflammatory drugs, and corticosteroids, like cortisol or the prescription term prednisolone. They are often used to relieve joint pain. The slower but longer-acting second-line medications, such as methotrexate and hydroxychloroquine, or quine, help put the disease into remission and slow down the destruction of the joints. Again, the pictures here show a woman with rheumatoid arthritis. Lyme disease is a particularly interesting clinical correlation because the spirochetes are basically anaerobic organisms. They are kind of an eccentric category of bacteria because of their unusual cellular morphology and distinctive mechanism of motility. So they look like a spiral corkscrew, basically. But anyway, these spirochetes can cause what's called relapsed fever, and this is one of the symptoms for Lyme's disease, where basically the person in Lyme's disease actually does not require an intermediate, and you can actually get Lyme's disease. This particular spirochete can be spread from person to person by direct contact. You don't need to be bitten by lice or ticks. One of the side effects of Lyme disease is inflammation of joints, and therefore the person presents with arthritis, inflammation of the joint. Interestingly, the organism that actually causes Lyme disease, just so you know, can cause what's called relapsing fever. And the reason why they can do this is because they can alter surface antigens during the disease course to avoid immunologic detection. So the person's immune system detects this spirochete, launches an immune response, abates the fever, etc., and the organism is basically curtailed, and then it changes its surface antigen to become antigenic and pathogenic again, and then it takes time for the person to detect that pathogen and elicit another immune response. And this was actually something that they were trying to rule out in me personally just last January 2014, when I had relapsing fever. Every 4 to 5 days, sometimes 7 days, I would be fever-free, and then I would have a severe debilitating fever that would last anywhere from hours to days. And one of the things that they were worried about was that I had been bitten by a tick or had contracted Lyme disease. And they were never able to grow up the pathogen. They were never able to conclusively prove that I had Lyme disease. I had no bites. I had no bullseye presentation. It was all a big mystery. Regarding bursitis and tendinitis, anytime you read the suffix itis, it basically means an inflammatory response. So an inflamed bursa or inflamed tendon, it basically is an inflammation response. There's a lot of irritation, and with NSAIDs, the inflammation can be curtailed. With torn cartilage, I told you about arthroscopic surgery to go in and clip off the torn edges of the cartilage, particularly of the torn torn menisci. There's also the last bullet here, artificial joints or arthroplasty. Surgical joint replacement is also referred to as arthroplasty, and it may be performed after failure of other non-surgical approaches like the NSAID therapy. Before surgery is considered, treatment regimens include activity modification, use of braces, even encouraging certain types of exercise, medications such as the NSAIDs that I told you about, the non-steroidal anti-inflammatory drugs, NSAIDs, or NSAIDs as they're called, and or they can use corticosterone supplements or injections like the prednisolone that I was telling you about into the joint. And surgery involves removing the damaged cartilage and joint surface, modifying the bone architecture to align the joint properly, and then a metal or a plastic prosthetic is implanted to replace the joint surface. The options available, materials used, and recovery time are dependent upon the joint being replaced. For instance, hip replacement usually includes complete replacement of the head and the neck of the femur, and shoulder replacement includes the articular surfaces. The recovery time for total knee replacement surgery is the shortest, between 6 and 8 weeks, with full recovery expected within 6 months. Total shoulder replacement incurs the longest recovery time because the joint is immobilized between 6 and 8 weeks before extensive physical therapy can begin. As materials and methods advance, the longevity of the replaced joint has lengthened so that between 75% and 95% are still functional after 15 years. Now I have to tell you, I have a very young cousin. Well, at this point he's 40, almost 40. And when he was in his young 20s, he was in a very severe car accident with his sister. And his sister, also my cousin, her name was Tara. She was tragically killed in this accident. Horrific. And her brother, my cousin who is still alive, he had a severely fractured, quote, hip, which we know now in this class to be really the head of the femur was fractured. He actually had some of the bones of his os coxae fractured as well. I mean, it just crushed his hip. So he's had to have hip replacement similar to what you see in this picture. He has a lot of rods and screws, and he's a mess right there. And he will likely have to have a couple of, quote, hip replacements throughout his lifespan because they last only so long before the screws and the bolts that are anchored in the bone, well, those are deemed foreign, and your immune system will attack those and kind of, you know, like a screw that you might go into drywall and you need kind of an anchor. If you don't do that, if you just put a screw in drywall, it gets loose, right? It won't hold a picture frame or even a nail in drywall. So very similar in joints. If it's screwed in or nailed in, eventually the bone degrades and that anchor gets loose, like a nail gets loose in drywall. And so you have to replace them, and you use new screws and bolts, etc., and you drill them into different places of the bone where it's a tighter fit. But again, these typically last about 15 to 20 years. So my cousin, sadly, is looking at a lifetime of at least a couple of hip replacements. That concludes our discussion on Chapter 9, Joints. Goodbye.